Under pressure, the body's response to increased intracranial pressure, ICP. A 31-year-old woman presents to the hospital with a 3-week history of intense headache and blurry vision. The headaches were holocranial, throbbing, worse in the morning and while lying flat. She had experienced transitory, second-lasting visual loss with bending over. Additionally, the patient reported transitory diplopia, nausea, and bilateral pulsatile tinnitus. There were no recent head injuries or fall. On physical examination, the right pupil reacted sluggishly to light. There was limited left abduction. Fundoscopy revealed moderate papilledema. Mental status, motor and sensory examination, coordination, gait and reflexes were intact. What could be the diagnosis? Increased intracranial pressure, ICP, involves elevated cerebrospinal fluid, CSF, pressure in the cranium, which is normally between 10 to 25 cm/2 in adult in a recombinant position, primarily caused by an increase in the volume of blood, CSF, edema, or space-occupying lesion, such as tumor or an abscess. It may be idiopathic or caused by various medical conditions or neurological injuries. It is a critical medical concern as it can lead to severe neurological complications and life-threatening situations.
To better understand this case, we should review the pathophysiology of increased ICP. The Monro-Kellie doctrine defines the 3 components in the rigid cranium: CSF, blood, and brain parenchyma. An increase in any of their volume leads to intracranial hypertension. This decreased absorption or increased production of CSF, brain swelling or space-occupying lesions in the brain or cranium, and increases in blood volume will cause intracranial hypertension. Increased ICP irritates meninges and vasculature. A very important characteristic of our patient's headache, which is part of the Snoop 10 list of red and orange flags for secondary headaches, is the worsening in recumbency and in the morning and its association with emesis. CSF from the subarachnoid space flows into the optic nerve sheath. Axoplasmic flow stasis from the raised ICP presses on the optic nerve, leading to its swelling and papilledema on ophthalmoscopic examination. Rapid increases in ICP cause a decrease in cerebral perfusion pressure, which is the difference between mean arterial pressure, thus induces Cushing's reflex and causes bradycardia, systolic hypertension, and irregular breathing. Any change in mental status may suggest impending brain herniation from increased ICP. In patients presenting with signs of increased ICP, start with the assessment and management of airway, breathing, and circulation. A complete history and physical examination are crucial in guiding further evaluation and management. While taking history, ask the patient about headache localization, severity, onset, character, radiation, and associated factors that include emesis, pulsatile tinnitus, blurred vision, double vision, or photophobia. Also ask about aggravating factors and relieving factors. A typical headache due to intracranial hypertension gets worse after awakening, lying flat, bending over, coughing, and sneezing, all of which further increase ICP and may trigger ocular symptoms. On physical examination, first assess the vital signs looking for the Cushing's triad.
On fundoscopic exam, evaluate for papilledema. Examination of cranial nerves should include evaluation of extraocular muscle weakness, suggestive of increased ICP. Furthermore, unequal or non-reactive pupils on pupillary examination could be a sign of intracranial hypertension. You may also consider doing a lumbar puncture to measure ICP. However, be sure to remember the absolute contraindications, including possible raised ICP with risk for cerebral herniation due to obstructive hydrocephalus, cerebral edema, or space-occupying lesion. Our patient had normal brain MRI and MR venogram. Lumbar puncture showed opening pressure of 33 cm water and normal CSF analysis. Acetazolamide was started for idiopathic intracranial hypertension. Remember the symptoms of increased ICP: positional headache, emesis, and visual symptoms. Watch out for mental status changes and the Cushing stride as a sign of acute raised ICP. When considering lumbar punctures to measure ICP, remember the absolute contraindications, including possible raised ICP with risk for cerebral herniation due to obstructive hydrocephalus, cerebral edema, or space-occupying lesions.
For more information on increased intracranial pressure, including a NeuroBytes video on the management of increased ICP, please see the course resources. For more information on this and other neurological condition, please visit an.com/neurobytes.